Assalamu alaikum. Dr. Hussain Bush Kolachi YouTube channel is with you, and today we will discuss dengue fever in Pakistan, epidemiology, outbreak dynamics, seasonality, and prevention with a WHO fact sheet at a core. So this is important because the dengue season or this monsoon season, and then followed by uh, we call it autumn and the start of the some winter, the dengue fever is emerging in Pakistan, and this is one of a great public health problem as well as emergency. It creates a lot of fear, lot of panic, and even the authorities, they are conscious about this problem because this has been repeatedly affecting Pakistan since last 3 4 decades. So let us move to another slide, and if I can change it, okay. Yes. So Pakistan has year-round transmission, but risk accelerates after the rain. So this is the exact season because few weeks ago and few days ago, the rain in Hyderabad and in the Pakistan monsoon rain and its regular showers had happened, and most of the area is now under clouds as well as under the monsoon. So you can see that the virus is serotype 1 to 4, and we call it BENW, uh, BENV4. And main urban vector is Aedes aegypti and Aedes albopictus, and 74% of confirmed cases in the 2022 WHO snapshot arrived in September. So September, you know that we are in August, and today it is the 9th August, and just 2 3 weeks are there, and we will enter into the September, which is the proper season for dengue, malaria, and other monsoon fevers. 1 to 2 weeks typical recovery window for uncomplicated illness. 2 3 weeks or 1 2 weeks are important. Uh, then we have flooding, standing water, and population movement amplified a late season surge. And this was WHO data, which shows that 25,000 cases and almost 60 plus cases were the case fatality rate of 0.25%, which is less, but because of this preventable cause, the dengue fever is one of the important public. And from Sindh, you can see that out of these cases, number one is the province of Sindh. So this is important, and this is the area where the government of Sindh should focus more, followed by Punjab, KPK, Balochistan. So no province is left, and we are connected countries, and our population movement is one of the fastest. So it is not only the Sindh or Punjab, but we are moving every day in millions from one province to other province, one city to other city. So let us move further. The practical alert window is monsoon, which is now through post monsoon, roughly July to November. So we have to be one of them. From the graph, you can see that the monsoon and post monsoon both give rise to the graph, and the relative risk is higher in these. And warm temperature, rainfall creates small breeding containers, and transmission can continue outside the peak window because Pakistan is endemic. Then urban density, water short storage practices shape local risk. Household open drums, rooftops, tanks, plant sources, discarded tires. This is important in Pakistan because the first outbreak in Lahore was near the airport where these old tires were stopped and rainwater was there, and that led to the outbreak. Communities, high population density, and unreliable water supply, mobility, and weak waste management, which creates blockage and drainage and water pipes. All these things are there. And even the stagnant water and the water supply both are not safe and properly maintained. Health services, outbreak, stress, diagnostic capacity, triage, platelet monitoring, referral pathways, and public communication for which we are making this video. Climate signals, heat, rainfall, and humidity are linked to the changing vector suitability and longer transmission season. Then most infections are mild. The danger is missing deterioration after the fever falls. Common symptoms, warning signs, especially severe abdominal pain, persistent movement, bleeding, lethargy, rapid breathing, or cold, pale skin. Use paracetamol for fever, avoid aspirin, and uh, ibuprofen, we call it here in a different names, unless a clinician advises otherwise. So typically incubation period, this is interesting for the students of fourth year and MBBS, that what is the incubation period, 4 to 10 days, and severe dengue cases fatality can be achieved with timely recognition of appropriate care less than 1%. Vector control is the main intervention. And when I say vector, it is the mosquito Aedes aegypti and Aedes albopictus. So these are two main, and here remove the water, cover the container and tanks, protect, use the repellent, long sleeves means full clothes, and mobilize, run neighborhood sources reduction and risk communication campaigns. Uh, Search, destroy, and cover is more durable than reactive fogging alone. Operational principles for local dengue control should also be developed. And then a 7 day response cycle can turn surveillance into action, detect, confirm, target, review. The key is not a single intervention, it is fast loop between surveillance, vector control, clinical care, and community trust. The trust of the community in the government sector hospital is less, while private sector is very costly, and to get the treatment at a private level and the facility is not for the majority. So the government should provide a lot of services as well as the electricity, separate wards, trained doctors, as well as the ambulance and other services with a very good nursing care. Then 5 facts to keep on every clinic and community poster. Transmission, infected female Aedes mosquito spread dengue mainly during the day. This is important. Burden, WHO estimate 100 to 400 million infection globally each year. Risk a second infection with another serotype can increase severe disease risk, and the care, early detection, fluids, and monitoring sharply reduce the fatal outcome. Uh, the highest value move is early and local and boring. The highest value move is early. Eliminate breeding sites every week, protect against daytime bites, recognize warning signs early. As already I have told that and use surveillance to direct resources before hospital fill. So households weekly water container routine, triage, warning signs in the clinics, districts, hospital maps, rapid response communities, and trusted repeated messages. This is important. That's why we are making this video. I think with this we are ending towards last of this video, and I hope you have understood better. But I think there are certain mosquitoes, certain insects. Particularly, I will request the one of that is dragonfly, which is normally seen in the rural areas and around the hedges. It eats the larva as well as there are certain fishes which also eat the larva and as well as the breeding places and monitoring and early surveillance in which in Lahore I have seen in the Institute of Public Health. I appreciate the efforts of the director and dean of the Institute of Professor Dr. Saira Afzal, and they have a small cages or some kind of trappers in which they are placed in different sites in the Lahore, and ultimately they are brought to the Institute of Public Health, and the entomologists and other experts they see that in which trapper or in which container the mosquitoes are more about the agitated type, then cause the they will identify and direct the DHO and the DG and other staff, and even their own system provides the risk communication and all this. So with this, I think we are stopping this. Thank you very much, and please like, share Dr. Hussain Bashkolachi YouTube channel, and we shall be giving you a lot of information about the public health issues in Pakistan, so it is relevant to the other South Asian countries and to our country. Thank you very much.